Well, here we go again. I guess we're going to have to listen to me ramble. I promised you guys with my COVID-19 Alaska at-risk video yesterday that I'd get a I think I have COVID-19, what should I do lecture out. I'll be honest with you, I've been really drilling down on this to the best of my ability, using my Bubba biology primarily as the driving force for making opinions that are going to answer that question for you today. I pretty much watch the task force almost every day when I can. I think that's, the legitimate information that we're being fed, and then I follow up on what I learn. I got an outline here. Tomorrow I'm taking the day off unless something drastic changes in the next day where I feel like there's just information that's hard to digest that I need to cover for you guys. I do have an outline, and I started with some basic truths. I don't think I have to quote research for this. We all know this is a highly transmittable disease, and that is one of the big problems with it. The lethality is a real concern, and particularly if you're compromised from other diseases. I think these are pretty well established. From what I've seen, the highest frequency of disease associations in ICU patients is hypertension, diabetes is up there, lung disease and heart disease. Recalling my original lecture, the lung's the air exchanger, that gets compromised by the disease. The heart's the pump that delivers the oxygenated blood to the target end organs, which end up compromised and kind of resulting in the sequential tight spiral of death. If you die from this, those two are obviously going to be significant. Immunocompromised, people who don't have healthy immune systems, either from poor health or medications that they're taking. Obesity leads to hypertension, diabetes, heart disease, lung disease. It's also a marker of systemic inflammation. Not surprising. Age is probably a risk factor because as we age, all of these things become more likely. Independently, it's probably not going to be a huge risk factor. In other words, if you happen to be an old guy in great physical condition with no heart disease, pretty good lungs for your age, have really good insulin sensitivity, really good blood pressure, you eat a great diet, you're not on any medicines that immunosuppress, and you're lean, I bet you're not going to have nearly as bad an outcome as if you're old and sick. People, as they get older, get sicker. Race. This disease doesn't care what race you are, but some of the races, blacks and Hispanics, which I see a lot being thrown around in there, are having worse outcomes, have higher incidence of obesity, heart disease, diabetes, hypertension. I don't know the statistics. They may have higher cigarette use and smoke more, have more lung disease. Okay, so here's Bob's proposed science. If I could conduct a study in the future that looked at positive health risk markers, I bet I could prove they would show better outcome. So like if I could have access to a large patient data bank that got COVID-19 and I knew what their outcomes were, and I could have access to what their pre-test or infection information was in terms of hemoglobin A1C or average blood sugar, fasting insulin levels to give you an idea of what their insulin sensitivity was, their fitness levels, their VO2 max, which is a direct measurement of their heart and lung function, know that they had good, well-controlled blood pressure to begin with. I'd love to know omega balances in their cell walls and cardio-CRP, a marker of blood vessel inflammation to start with. And I'd love to know how much visceral adipose tissue they had. I'll bet you if I could create a scoring system where a high score meant you had a lot of negative markers in all of those testing categories, and a low score meant that everything looked great, people with low scores would have very low incidence of bad outcomes. There's always going to be outliers, okay? You know, but statistically speaking, your risks would be way low. All right, probably never going to see that study. What else do we know? Well, we know that quarantine and social distancing works, okay? It will save lives this round because it prevents the overwhelm phenomena, where we have people dying that could have been salvaged because we exceed the medical system's capabilities. Hey, there's been a lot of concern that that was going to happen in this country. It happened in France, it happened in Spain, we know that. We don't know what happened in China. Data's not valuable. The reality is, from what I understand, nobody's needed a ventilator and not got one yet. Now, in some small town stuff, like we talked about in Alaska, that's going to happen, but you know, those are typically scenarios where we always stabilize critically ill patients and then try to transfer them to a center where they can get a more advanced level of care. So with that caveat, I think we got the ventilators under control, and if we don't get some sort of resurgence, looks like we got this as far as ventilators and even hospital beds. As far as I know, we haven't turned people away that were going to die otherwise. This whole quarantine social distance thing will save lives the next round because the delay will allow prevention, vaccinations, and probably a better understanding of how to treat this when we've had time to digest all the studies in all the various countries, right? Right now we're doing studies as rapidly as we can and trying to grasp that information. Okay, we also know testing is important, so I want you to understand testing, okay? So this Abbott test is like maybe a real game changer, promising, right? I did everything I could to try to determine what the sensitivity and specificity of that test was. Can't find it. It sounds like it's pretty highly sensitive, meaning if you have COVID-19, it will probably detect the RNA of the virus in the specimens collected. These are nasopharyngeal swabs, primarily, and it probably won't miss it, meaning it's pretty sensitive, but I couldn't get a number. I can't tell you it's 98% sensitive. They're not publicizing that. Probably data to eventually be available. I think it's also fairly specific, meaning you're not likely to test positive if you don't have it, which is what that term means. Those are useful things, and I wish we knew them. We don't. It's fast, which is great. This is the same machine that's present in about 18,000 places in our country. I believe the machine we have in our urgent care center that tests for influenza and RSV very rapidly is the Abbott machine. So if we could get the cartridges, we could test you right there at the urgent care center. But therein lies the problem. The company can only make 50,000 cartridges daily. So we're still using those according to certain testing guidelines, okay? And I'll go over those in a bit. Now, the second test that everybody's all excited about is the antibody test. Now, that test is determining if your body has produced antibodies to the virus, which would indicate you've been infected. Doesn't prove that the infection's over and that you're not infectious anymore. But does tell us that you've been exposed in conjunction with a negative viral test of high specificity and sensitivity would be really good information because those people could certainly go back to work, right? You don't have the virus and you've got antibodies. They would be great to get back. But Dr. Fauci says it's going to be available next week, so we're not there yet. So it's great for figuring out infection rate retrospectively, and that's where I think we're primarily going to use this test. Someday we're going to know the mortality of this by going back and seeing what percentage of our population got it through random evaluation. I suspect that when the test is readily available and it's all over the place and we know we can get it, we're going to test all our healthcare workers because we're going to want to know, A, for round two, who do we know is immune, and B, how likely were you to get it because you were a frontline healthcare worker. So we're going to test the healthcare worker system. And then, obviously, we're going to want to test the people who got the disease to see how good of an immune response the population generated. But what we're going to want to do is grab a section of the population randomly that, regardless of whether they ever had symptoms or not, and test so that we get an idea of what the incidence of the disease was. Then you figure out how many people died and you'll figure out your mortality. I will predict it's going to be well below 1%. I think if I'm looking at the numbers correctly in this country right now, I want to say we're at about 3%. There's some places where it's 7%, 8%. It's not been that high anywhere, I don't think. That's just me kind of grinding up data, looking at the charts and stuff. I think it's going to be less than 1%. It's not going to be as low as influenza, the 0.1% that they quote. It's a pretty lethal virus. I mean, it's got some bad juju about it. But I'm putting myself out on the line there, less than 1%. If I had to guess, I'd say around, it's going to be between 0.3 and 0.5%. It will establish whether there's herd immunity or not. That's where it's going to be useful. Okay, so my next bullet point is testing worldwide. Hey, I found a pretty cool site. Kind of helps us to understand how we're doing as a nation. Okay, so here's a few graphs here. So this is, and this was on ourworldindata.org. So I'm sure you can Google that if you want. So here we look at different countries and who's done the most testing. And I put in, you can actually add countries as you want. I threw the ones that were interesting in there to me. Take a look here. The U.S., 2.5 million tests have been done. Oh, we're killing it, okay? I've heard some maybe politically generated statements about we've got more positive tests than everybody else, like somehow we're failing because of this. And I've heard a lot of talk about we're not, like, how come we haven't been able to test for this adequately? I mean, there's some countries that have done really well, as we'll see as we go to the next slide. I think there's some countries that have, impressed me how well, South Korea being one of them. But keep in mind, the molecules we're testing for, we didn't even know about 3 months ago. So to have generated 2.5 million tests on something we didn't even know existed and didn't become a predicament in our country because our curve is behind the curve of these other countries, right? First of all, we blocked travel from China, which probably protected us some. We did that early. So we're behind some of these other countries. So our need for testing didn't rise as quickly, or we weren't made aware of it. The World Health Organization and China was lying about how dangerous this thing was. So there was a false sense of security. Hey, we've tested way more than anybody else, okay? Which is one of the reasons why we have way more cases than anybody else. All right, now, this is an interesting graph because it shows the number of tests per 1,000 people, okay? And there you see that there's two big name countries that are beating us. South Korea, this very linear red line, they really got on it, and they did a great job squelching it, but with draconian measures probably beyond our capability. Italy, who has had the worst situation of any country that we're aware of, again, throwing China out because we don't know what's happening there. So Italy has tested the most per 1,000 people, okay? But the U.S. is coming in third, and if you'll notice, ours is kind of exponentially growing. We'll pass those countries per capita because of what a great country we have and the economic engine and how industries working with the government. And overall, I've been impressed with our response to this, and overall, I've been impressed with what the American people have done to try to save their fellow citizens and to flatten this curve, which it seems like is working. The United Kingdom's well below us. France is well below us, and they have bad disease. They didn't have Spain on this for some reason, which I would have pulled up. And then this shows you COVID tests per day, and as you can see, there's nobody testing as much as we are right now. So we're ramping up consistently in the U.S. In terms of the amount of tests we're running per day. So we're getting on it. We're going to learn a lot more about the disease. All right, so that tells us that bullet point on testing. Let's see what was next in my outline here. All right, testing in the United States. Just another great slide site I thought I'd share with you. This is from Politico.com. It shows kind of hot spots. Interesting again, our percentage of positives and the death. Let me see, I guess I could do the math on that. We got 523,000 positives and 20,000 deaths. Maybe that's a little higher than 3%. My math's not good, as I'll share with you in a little bit. But anyways, and then the number of tests given, 2,665,000. So that's for the United States. But this thing comes down and gives you, shows you the areas. It gives you a big circle if you've got a lot of cases. It's kind of a hot spot deal. So you can see that Alaska's got a tiny circle, Hawaii, and then it goes down through states. But I kind of like this one because it gives you an idea of, you know, the number of tests, or the total number of tests, 440,000, positives, 180,000. This is for New York. That's where I alluded in my lecture yesterday. Hey, if you're in New York and you have symptoms that are consistent with COVID-19, you probably got COVID-19. I mean, there's a pretty high positive predictive value if you're getting a test. Whereas, down here in Alaska, we're way down here, all the way at the bottom. Look at that. Okay, so here's Alaska, and I was wrong, okay? I was off by a decimal point. The positive percentage test, the percentage of tests that are positive in Alaska is about 3%. One of the Alaska coronavirus fighters, task force members on the Facebook group I'm in pointed out my mathematical error. I'm not great in math. I used to be, but I just don't do it enough anymore. Anyways, I decimaled it off. We're still staying at about 3%. This is as of April 11th. And what we see here, I know it's hard to read the top number, but it's 7,732 tests, 257 positives. I did the math again today. We're still at 3%. So, if you have symptoms and you're in Alaska, you probably still don't have COVID-19. So, the pretest probability of a positive test is going to vary considerably just based on where you live, as well as other factors like known exposures and stuff. Okay, that's a good site too, that might come in handy for people. All right, back to the outline to make sure I don't miss something. Okay, current testing guidelines. So, this is from the CDC site, and I just want you to understand that this is basically what's driving who's being tested, okay? So the priority, the high-level people that get tested, all those tests that we're looking at, those 2,600,000 and something thousand tests that have been done in the country thus far, okay? The priority number one has been to hospitalize patients and symptomatic healthcare workers. Pretty much all of those are getting tested, okay? If you have fever, cough, sore throat, fever, cough, shortness of breath, or two of a number of other symptoms, you're probably getting tested if you are hospitalized or you're a healthcare worker. And most of these priority 2 people are probably getting tested also, okay? So, long-term healthcare facility and you've got symptoms. Over age 65, the underlying conditions that we talked about, and a first responder with symptoms, okay? I think they're talking firefighters and police, essential. And then priority number 3, as the resources allow, test individuals in the surrounding community, okay? To decrease the spread. But right now, resources don't allow that so much. Individuals who do not meet any of the above criteria with symptoms healthcare workers and first responders, meaning you might test a healthcare worker even without symptoms. Don't test individuals without symptoms, okay? So, all that testing is being done in a tiered fashion based on how important it is that we know if you have it or not, what the likelihood is that you would have it based on exposures and such, what the likelihood is of a bad outcome if you were to test positive and that kind of thing, to help drive decision making. As testing becomes more available, we'll see higher percentage of people get tested. All right, back to the outline. All right, so what would my assessment and treatment approach be? All right, well, I got to go back to a little bubble biology here. And so I want to talk to you about the difference between proof and biological plausibility. And I'm going to talk to you about, so first I want to talk about this evidence-based. This is a word you're going to hear thrown around by a lot of academics and lots of disease model doctors that talk about everything that they want to do is evidence-based. And I think sometimes they confuse evidence-based with proof, because something can be evidence-based but not proven, okay? I'll give you an example. I would say it's evidence-based that in most aging men and women, that hormone replacement or hormone therapy probably results in lower mortality. I'll take the testosterone example, since I take testosterone to maintain my levels close to a youthful 25-year-old males. I'll give you the rationale for that, and then we'll talk about whether it's proven and whether it's evidence-based. Okay, so in order to prove it, we would probably have to find a large number of patients willing to undergo a randomized, double-blind, clinical controlled trial and follow them for a long time to see whether more of them died or not, okay? Probably never going to happen in the perfect standard, which is double-blind, randomized, clinical control. First off, the best way to deliver it, I think, is intramuscularly. So you'd have to find a group of people that would be willing to give themselves fake shots, not knowing it, for years and years and years, and be in this follow-up group, to be in the control group that has a placebo, okay? So we probably won't ever prove it, but what can we look at? Well, first I like to look at biological plausibility. So with hormones, you can start with just the very basic concept of what a hormone is. A hormone is a molecule that is created by an organ in your endocrine system that binds to receptors on cells throughout your body, that is then transported to the nucleus of the cell, where they turn on DNA that transcribes proteins that makes your cells work properly. And as we age, they decline, and as we age, we see a decline in cellular function. So it's biologically plausible that keeping those hormones at youthful levels might help your cells to function better. Then we can start to look at other data that supports this concept. Well, what if you look at men who were not given adequate testosterone levels throughout their life? People that are in the hypogonadal portion of the population through naturally occurring problems, Klinefelter syndrome or any other various issues. A person's testicles didn't descend and it was missed and they just don't produce testosterone. Well, what we know is those people die at a much younger age from metabolic diseases. Then we can also look at what happens to people as testosterone levels naturally decline. Well, we see decline in other things that we know can be reversed with testosterone. For example, testosterone has been proven to immediately improve insulin sensitivity. So as testosterone declines, we see a rise in the incidence of type 2 diabetes. We know that testosterone therapy generally will help a male lose central fat. We know that central fat is associated with insulin insensitivity, systemic inflammation, increased risk of type 2 diabetes, all kinds of things like this. So I guess I'm not going to keep giving examples, but the point is, okay, well, here's a couple others. We know that low testosterone is associated with low bone density. We know that low testosterone is associated with loss of muscle mass. We know that testosterone is a drive hormone. It helps us to be more vigorous in life. And we can show through pre-existing scientific studies that if you take testosterone, you can exercise harder and recover from exercise better. We know that bone density increases in men on testosterone replacement. We know that central fat tends to be lost, and we have proven that insulin sensitivity improves. So, knowing that all those things that I'm discussing are risk factors for chronic disease, it's fairly reasonable to presume testosterone might help you prevent chronic disease, especially in the context of it's used as part of a overall lifestyle modification where it helps you to be more motivated to exercise, recover from exercise, yada, yada, yada. So, some physicians would say what I'm doing is not evidence-based, but they're full of crap, okay? It's evidence-based. I read all kinds of evidence on this stuff. It's not based on any evidence they know because they have cognitive dissonance. They do not pay attention to that evidence. Now, they could argue I can't prove it, and that is true. It's more inferred. All right, got it? Conceptual model. Now, hydroxychloroquine Z-Pak logic. Okay, let's look at the evidence, okay? Well, turns out there is some cellular evidence, okay? This was a study, this was conducted, that showed that, let me get down to the punchline, basically looking in cellular studies, what they call in vitro, they found that a high concentration, they surmised that one of the things that this hydroxychloroquine may do, it's a medicine that's used in people who have inflammatory conditions like lupus and rheumatoid arthritis, and so it has an anti-inflammatory effect. And we've already talked about, my very first lecture, the cytokine storm being the kind of the thing that just, predates the disaster in these patients that die. So it probably has some effect there. But they also showed that it was reducing viral load, basically, and viral replication in this study. Let me find I'm sorry, guys. It's always hard to highlight everything I want to point out in these things. 2 drugs efficiently inhibited SARS-CoV-2 infection in vitro. That means in the lab in cell studies. And one of those drugs was chloroquine, and then the other one, hydroxychloroquine. February 23rd, there's a bunch of trials going on. They evaluated antiviral effect of hydroxychloroquine, and basically they showed it works. Okay, that's the point of this study in Nature, in this thing. Now, back to make sure I don't get sidetracked here. Let me go back to the outline. All right, so that was cellular evidence. I believe my next study that I have up is human evidence. Oh, this was just this was a letter to the editor. I think I highlighted what I needed to, there we go. Okay, so here was their letter, this was their assessment of that study. Chloroquine is a cheap and safe drug that has been used for more than 70 years, and therefore it is a potentially clinically applicable against the 2019 nCoV. Our findings reveal that remdesivir, which is an antiviral that they also were looking at in the study, and chloroquine are highly effective in the control of 2019 nCoV infection in vitro. Since these compounds have been used in human patients with safety track record and shown to be effective against various ailments, we suggest that they should be assessed in human patients suffering from the novel coronavirus. So they're on board after this cellular study. All right, and then the next thing that I was coming to is some human studies. Now, these are going on, but we don't have the final data. This one was a randomized clinical trial done in China, okay, in Wuhan. And so the quick abstract, February 4th, 62 patients in this hospital in Wuhan, 2 groups of 31 patients. They felt like they were randomized. And here's basically the Cliff Note version. Hopefully I can find what I want to say quickly on this one. Of the 62, this was a study that Dr. Oz pointed out. And the big takeaway points, I think, can easily be covered in this chart here, if I'm not mistaken. Yeah. Okay. So here was the big takeaway points. And Oz pointed this out, and I thought he did a good job. This was a while back. So, looking at the control versus the hydroxychloroquine group, the 3 main factors. Fever, day since onset. In the control group, 3.2 days. In the placebo group, 2.2 days. And it met statistical significance. So it cut their fever shorter by a day. Cough, control group 3.1, 2.0. Again, met statistically significance. Progressed to severe illness, 4 in the control group, none in the placebo group. I'm sorry, in the treatment group. And the study's been criticized because it's small and there's methodological flaws, but let's face it, it points in the direction that maybe this stuff works. And we need something. People are dying if you hadn't figured that out. And once in a while, Bubba biology and biological plausibility has to force our hand. If you're going to wait around for the testosterone outcome studies, you're going to be old and frail by the time they come out. All right. My opinion. Now, I got another human study here. Hydroxychloroquine. This is a downloadable PDF. And azithromycin as a treatment. This is from France. It's a small study. Basically, they created a control group because people refused to be in the treatment group. So totally non-randomized, right? So it says so here. They found it to be single arm. Basically, they used some people that refused treatment as negative controls. So it says, untreated patients from another center and cases refusing the protocol were included as negative controls, okay? And what they looked for was, could they prove that the virus was becoming less detectable more quickly, okay? And basically, the conclusion, despite the small sample size, survey shows that hydroxychloroquine treatment is significantly associated with viral load reduction and disappearance of COVID-19 patients, and its effect is reinforced by azithromycin. And they had some quick and handy graphs that are easy to understand. Now again, remember, these are concocted control groups, not a perfect study, but here's the control groups, the amount of virus being detected at 6 days. Here's the treatment group, and that's for hydroxychloroquine. And then they throw you in a graph where they added the azithromycin, and again, control, just hydroxychloroquine, and with azithromycin. Okay? Amount of virus. Clearly could have an impact on transmission if you're preventing the virus from continuing to be shed at high levels. It's not perfect science, but it fits that it looks promising. I'm glad we got lots of this stuff being made. One of the things that you see in medicine is when there's a big dog in the fight and somebody's going to make a bunch of money, the studies get cranked out pretty quick. And if there's statistically significant evidence, boy, you know, it makes the news because, well, that's just how the system works. You know what? Hydroxychloroquine and Zithromax, 2 generic drugs, the combination of both, how much it costs? $20. Nobody's going to get rich off of these babies, which makes, to me, the data a little more reassuring. Nobody's got a dog in this fight to make these two drugs look like they're promising, meaning there's not an industry that's going to get rich off of it. There may be some political dogs in the fight, and I wish we could get those out of here. All right, I think I still got one more thing to ruminate over. Okay, now this is a kind of a cool study. This is 80 COVID-19 patients, 6-day follow-up, observational, okay? So I don't believe there's any randomization here. This is back in France. This is in France again. They took 80 patients, treated them with hydroxy and azithromycin, and they noted clinical improvement in all but one, an 86-year-old patient that died, and they said that guy was like so far gone that, you know, it wasn't surprising. And then a 74-year-old still in the ICU. They detected a rapid fall in nasopharyngeal viral load supporting the previous study, with 83% negative at day 7, 93% at day 8. They pointed out later in the discussion that since in the Chinese studies, people were demonstrating virus for 21 days, that's pretty significant. I think the final, hopefully I highlighted it, can't remember for sure. I think the final assessment, here we go. Okay, this was their conclusions. By administering hydroxychloroquine combined with azithromycin, we were able to observe an improvement in all cases except in one patient who arrived with an advanced form who was over the age of 86 and in whom the evolution was irreversible. For all other patients in this cohort of 80 people, the combination of hydroxychloroquine and azithromycin resulted in a clinical improvement that appeared significant when compared to the natural evolution in patients with a definite outcome as described in the literature. In a cohort of 191 Chinese patients, of whom 95% received antibiotics and 21% received an association of lopinavir and ritonavir, those are antivirals, the median duration of fever was 12 days and that of cough 19 days in survivors, with a 28% case fatality. So basically they're saying it looks like, compared to what we've seen from other studies that looked at how people's outcomes were in places that preceded the disease here, they look like they were doing better by giving people hydroxychloroquine and azithromycin. Again, doesn't meet the standard of scientific proof, but I sure like the way it looks. All right, what else do I have to go here? Okay, so my next bullet point was, is it safe? Safety. I think most people respect Johns Hopkins. I dug around looking for safety data. I've seen, again, I think politically charged rhetoric about safety. All of a sudden, you can't hardly use this stuff because it's going to cause fatal arrhythmias, although it's being used for many, many years on tremendously large numbers of patients for other medical problems. Malaria, rheumatoid arthritis, lupus. So, let's just look at what Johns Hopkins says. Okay, it says it's indicated for the suppressive treatment and treatment of acute attacks of malaria due to whatever malaria strains, and for the treatment of discoid and systemic lupus erythematosus and rheumatoid arthritis. Non-FDA approved uses, okay? Q fever, coronavirus COVID-19, Whipple's disease, brucella. All right, hydroxychloroquine sulfate, usual adult dosing. All right, our dosing is not as high as malaria, or say R, meaning if we're going to use it for COVID-19, and it's pretty similar to the daily dosing in lupus, 400 milligrams once or twice daily, 400 milligrams twice daily for 2 doses, followed by 200 milligrams twice daily for 5 days has been suggested, yada yada. So we're not talking about super high dosing. Rheumatological arthritis, 400 to 600 milligrams daily. So we're not talking about crazy high doses, okay? And we're talking about doses we're very familiar with using in large patient populations. What does the Johns Hopkins Hospital say about adverse reactions? Let's get that. Okay, so general long-term hydroxychloroquine is contraindicated for patients with pre-existing retinopathy of the eye or known hypersensitivity to the dry eye. Okay, you've heard a lot about it's going to make you go blind. Long-term. You don't go blind with short-term, okay? Use of hydroxychloroquine, okay, so it might mess you up if you have psoriasis. Okay, common side effects, headache, gastrointestinal complaints, blurred vision. Okay, no big deal. Occasional dizziness, bumping your liver functions. Hydroxychloroquine can prolong PR, QRS, and QT intervals, especially if you have pre-existing. Okay. So, it can cause some changes in your EKG that are theoretical concerns for arrhythmia. But, is it a problem? Rare. Cardiomyopathy, bone marrow suppression, hepatic failure, yada, yada, yada. All right. So, drug-to-drug interactions. I would have sworn they came up with a comment. Here's the comment. Hydroxychloroquine is a hydroxy analog, yet well tolerated, malaria, yada, 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 rheumatoid. Decades of use in chronic anti-inflammatory conditions and malaria prophylaxis suggest that it is a relatively safe drug with a low incidence of adverse events. Now, just to remind you, there's not a low incidence of adverse events if you're old and debilitated and you get COVID-19. You might die. Like, probably if you're in the right category, your mortality is 20%. So I probably like the idea of trying some hydroxychloroquine and Zithromax. You're probably gathering that depending on your group, okay? Decades of prophylaxis suggests, okay. And then retinopathy is one of the most serious adverse events, and it is not reversible. Ophthalmology, okay, it says, examination prior to therapy initiation to rule out pre-existing problems with your eyes, basically annual screening after 5 years. I'm not sure we have time to be looking at everybody's eyes before we try to save them. Okay? The FDA did authorize emergency use. That allows a doc like me to make my own decision about whether I would treat you with it or not. Okay? All right. Safety. Back to the outline. All right, safety. Reasonable strategy in some. All right. Do I think it's a reasonable strategy in some? Well, I think it is. We're certainly not the only country that is advocating the use of this. This is a Middle Eastern country. Where's New Delhi? I forget. That it's standard of care in this country based on their assessment of the data. So, you know, this is basically saying that, I mean, they're talking about using it for asymptomatic healthcare workers, for chemoprophylaxis, asymptomatic household contacts of confirmed laboratory cases. You know, they're definitely saying don't let that give you a false sense of security. So, I mean, it's being used. It's not like we're way out on the fringe here, okay? What would be my strategy? Well, I would say that I would break down, if a patient of mine, this will be the next thing we'll talk about, which is future testing. If a patient of mine contacted me and said, I think I have it. Now, because we live in Alaska, my index of suspicion is lower to begin with because only 3% of tests are positive. But maybe they've got really convincing symptoms, or maybe they've got a definite exposure, right? Because we do have people that we know have it, so I got exposed to this patient that just had a positive test and I have symptoms. Now my index of suspicion is way high. Now, if it was me, if I looked at that patient as I know them, and I looked at their inflammatory markers, and I knew what their fitness level was. I know this about all my patients. And I know they have very little visceral adipose. Their ideal body weight, they have no heart disease, they have no lung disease, they're not getting towards the extreme end of age, so another 50-year-old, let's say. And his score on my little scoring system is really low. I probably would say, I don't think I'd treat you with that. You probably aren't going to need anything. You're going to get better. Let's wait and see. Now, if that very patient who I had a really strong pre-test clinic of suspicion, that index of suspicion that they had the disorder, told me, I'm getting short of breath, Bob. Well, first off, I'd probably make them go get evaluated, because I think at that point we need objective measurements. But that would be somebody that would get treated, I think, you know. And again, depending on where we're at with testing, if I had the rapid test and it's sensitive and specific, and I could prove relatively quickly they didn't have it, don't treat, right? Save the drug for the rheumatoid arthritis and the systemic lupus patients who are now finding it difficult to get this drug, or for somebody that really is going to need the drug. Now, if I'm in a setting where I know there's no way I'm going to get a rapid answer, okay, it's going to be days before I find out whether my patient or not has the disorder. And my patient is old, not one of my healthier patients. I know he's got pre-existing lung disease. It's one of my patients that I take care of that's already had a heart attack. It's one of my patients that I know has poor fitness. It's a patient that I know has insulin insensitivity and obesity and high blood pressure. I'm writing them for the prescription, okay? So I guess the end of this talk, which was, so I think I have COVID-19, what should I do? I'm trying to get to that in a roundabout fashion. So here's what I think you do. First off, look at the state epidemiology. What's the likelihood that you have it? I mean, if there's none around, you probably don't have it. There's still lots of other viruses out there that can cause symptoms. Number two, are you in the high-risk group? Are you old? Are you obese? Are you with lung disease, heart disease, unfit, central fat, insulin resistance? You know you have systemic inflammation. You got a crappy diet. You're just a mess. Call your doctor. Figure out if you're going to make it into the testing realm and see if your doctor will prescribe hydroxychloroquine and Zithromax. I think if you're high risk and the pre-test probability is relatively high that you have it, I personally would prescribe to that patient group. So if you're in that group and you're really worried you have it, for whatever reasonable consideration, a known exposure, really convincing symptoms, or you are in an area where there's enough of it around that it's reasonable to think you have it, make the call. Follow the guidelines. Don't just show up at the ER. They don't want to see you there. They want to know you're coming, and they're going to do what they can to test, decide whether you definitely need an ER evaluation or not. All right. I hope that helps you guys get your head wrapped around, you know, if you're a healthy person and you think you've come down with it, unless for some epidemiological reason, like you've got an old person that lives in the house with you that's immunocompromised and you think, God, if I better know if I have this or not, because it changes things substantially in terms of that approach. Probably most of us, if we're young or well and healthy and we're not going to be compromised and we think we have it, you should step up the quarantine. You should try not to give it to the rest of the people around you. You got to quarantine yourself even from your family members. That's the right thing to do. All right, this is interesting. Future testing. This is a study that you can enter in right now, and it's looking at hydroxychloroquine as a prophylactic. And if you are somebody on hydroxychloroquine chronically and you have a known exposure, they're asking for you to enter into this data bank so they can follow you to see if you get the disease. Now, in one of those studies that I went back on, and I didn't want to try to dig it out, they did mention that they did search a data bank, and there was 150 patients that had lupus that were on hydroxychloroquine, and none have tested positive. But that's not a huge enough sample, because I don't think 1 in 150 people in this country have the disorder yet, I don't think. I mean, if you're in New York, they would. This would be very interesting because it would be powered large enough that you had known exposures, and I want to say they even were going to compare it to other known exposures. But it should answer the question, is this potentially an agent that could prevent you from getting this disease? That will be great when this data becomes available. Dr. Oz, I'd have sworn he made a statement that somebody had investigated a data bank, and I want to say it was they found, using Medicare and Medicaid data bank, 15,000 patients chronically on hydroxychloroquine, and then they somehow followed up on them and there was not one positive. Now that kind of number would obviously show that it's got some effectiveness in preventing the disease. But I tried and searched and I can't find that study or that research into that data bank. So there's things that are going to come, they're going to help, we're going to learn more. My approach, like I said, if you think you've got it, look at your state. Is there much around? Have you had a known exposure? Are you high risk? And then call your doctor for further advice. If I'm your doctor, you kind of understand whether I'm going to pull the trigger or not. I don't think you need a bottle of hydroxychloroquine in your back pocket to make sure you can get this drug if you get it. Most of us, if we get this disorder, are not going to need anything. Hope that helps. Happy Easter.